So got it. So this is information on the CMEs. If you have any questions, please reach out to Rana. I have nothing to disclose, nor do any of the other Hub team members, no financial arrangements related to the content of today's activity. We're going to be talking about the stages of change model, and then the spirit of motivational interviewing, which is sort of a foundational component for the MI intervention. So I'm hoping to go over the core concepts of the trans-theoretical model of change. So this can make sense in terms of utilizing this model to assessment and treatment of the substance use disorder population. I'm also hoping to go over a little bit about kind of how motivational interviewing applies to working with your patients, whether you're using the full intervention or not. Specifically going into detail about the underlying principles that are part of this spirit of MI. So hopefully those two things can be used sort of regardless of if you have any further training in MI or not. You can apply it broadly to all of the work that you're doing with patients. So let's start with the stages of change first. Why is it important to know about this model? So it's called the trans-theoretical stages of change model. It is considered an evidence-based model that explains where a person is at and what they're going to need from treatment. So it's not so much of an intervention as it is a model for accurately assessing and then matching treatment to patients. It's not part of motivational interviewing. It tends to go hand in hand. And so people can confuse them and assume that they're part of the same model. It is a separate standalone model that you can use with or without MI. And I'm going to talk about kind of where MI fits into the stages of change. So this is it in a nutshell. You can see that that it doesn't have like a one, 2, or 3, that it's just set up as an upward spiral. And I think that's an important part of understanding the concept of this model, because patients don't always move through each one of these stages in order, and they don't always, when they have a slip or a relapse, restart at pre-contemplation. So it's important to understand each one of these parts of the stages of change separately, and then also how they go together. The other thing to understand about this model is that this doesn't just explain how people with substance use disorder move through changing their behavior from unhealthy relationship with substances to a healthier relationship or a healthier set of behaviors. This explains how everyone moves through making any kind of healthy change in their life. So if you've ever tried to diet or exercise more or change how you budget or any of those things where it's in the service of a healthy lifestyle change, likely you've moved through some of these stages as part of that process. So I think that's important to note. This isn't just about substance use disorder. This is about how human beings go through the process of change. And recognizing that it's an upward spiral is important because habits are really, really hard to break, really, really hard to replace. So as humans, whenever we're trying to make healthy changes and we move through this process, we may be successful for a period and then have increased stress or have something happen that causes us to go back to old unhelpful patterns of behavior. When that happens and we re-engage with the healthy change again, we don't always start over from zero. We usually bring with us all the learning that we gained along that process. And so we can sometimes jump right back into action. We don't necessarily have to go and start at the beginning where we have no intention to change. So how do you start to utilize this model and think about where it fits? So let me go through the stages and explain a little bit about them. The first stage, and like I said, not every patient starts here, but this is where the model starts. So some patients are going to start actually in contemplation, but pre-contemplation means that they are not considering a change in the foreseeable future. That does not mean that they don't recognize a change is needed or not getting pressure from other people in their life or experiencing negative consequences related to their behavior. It just means that they themselves, for various reasons, are not considering changing. Contemplation is when they're actually shifting towards, okay, I'm considering changing in the foreseeable future. So that means in relatively close time. So in the next couple of weeks to months, I'm actually really considering and thinking about how I would like to make some changes in my life. Preparation is once I've moved through contemplation and I'm very clearly I'm wanting to make that change. Preparation is just planning what that's going to look like and when it's going to happen. And then action, we're firmly in action when we've achieved that meaningful change. So it's not starting the change, it's actually once we've done it. So an example would be, I've planned to decrease my opiate use by starting on Suboxone medication. So I've made the appointments, I've met with the doctors, I've gotten the prescription, and then I've actually started on that regime, and I have either cut back significantly or stopped using for several days. That's when I'm in action. So I'm actually in the process of making that meaningful change. And then maintenance is where that meaningful change is being maintained for a period of time. So that's where patients are at when that new habit has started. So why is it important to understand where patients are falling? It's important to use this model to be able to line it up with recommended interventions. And when people are in pre-contemplation, this is probably the hardest patients to work with because they can be labeled as unmotivated or not necessarily understanding or seeing the consequences of their unhealthy behaviors that they're engaging in. But when somebody's in pre-contemplation, that means they're not ready, they're not in a place where they want to make a change. Oftentimes that's due to lack of confidence in their ability, lack of resources. We know a lot of the patients that we work with feel a lot of learned helplessness or demoralization around their ability to make changes. And so motivational interviewing can be helpful, but it wouldn't necessarily be a recommended intervention for people here. What's really helpful for folks in pre-contemplation is to focus on making sure that you have a good alliance and good rapport. So making sure that patients really feel that unconditional positive regard, they feel accepted, whether they make a change or not, so that they can start to talk to you about why they're struggling with the situations that they're struggling with, what it is that the substance use is still doing for them, how it's helping them, and then what is it that it's maybe harming them or not helping them. That's that decisional balance conversation. That's a helpful thing to start to do with people in pre-contemplation. Once they've moved into contemplation, that means they're ready to make the change. They have some level of what's called ambivalence, and I'm going to talk a lot more about that here in a minute. So with contemplation, motivational interviewing is our number one go-to intervention, because that's really what's going to work with that ambivalence and start to capitalize on the motivation to want to make changes and shift people towards the preparation and action phase. Once somebody's entering preparation, they really don't need much intervention. They might need some discussions around legitimate barriers that are going to get in the way of their plan, accessing resources to support their plan, but we don't need to do any more motivational interviewing. They're ready to do it to start the plan. And then action, that's where we're going to shift away from MI into starting to do relapse prevention, because what we want to do is really support and bolster their self-efficacy, that confidence that they can do it, that they are doing it, and help them to move into maintenance and maintain that new healthy behavior and deal with relapses or slips when and if they happen, because we know that those are really more of the rule than the exception. And so we want people to be prepared that if they have a slip, that's just a return of the old habit. We can talk through maybe what did they miss, what warning signs did they not hit, and they get right back into action or even maintenance. They don't have to restart that cycle. Because remember, it's an upward spiral. They're bringing all of those skills with them. So we just need to help support and foster that self-efficacy. So when patients are in pre-contemplation, we really want to recognize that in terms of their goal, that there is a problem and we can validate that for them within the context of their life, rather than having to say, like, maybe they're unaware. 9 times out of 10, they're very aware of the consequences, but there are other things that are keeping them stuck in that in engagement with their use behavior. So we want to listen. What are their concerns? Reflect that content, reflect the emotions that are there, elicit more information, maybe past experiences when they've been stuck like this. What strengths do they have? What are their attitudes about their current use, or thinking about if that would look different? And then make sure that we're communicating that acceptance of this is where they're at, and they're in control of if they choose to make any changes or not, and really expressing that rapport building stuff, caring, empathy, and transparency. So that's important for pre-contemplation. If we try to use too much MI with folks that are here, we could inadvertently reinforce the sustain language. So they don't have enough ambivalence, or they may not have any ambivalence at all. And if there's no ambivalence, then we really can't use motivational interviewing. People that are in contemplation, this is where their ambivalence is shown up. So part of them is still engaging in the unhelpful behavior, but part of them is really wanting to do something about it. So our goal for them is to move them toward action. So really capitalize and keep them talking about the change. Why do they want to do it? Why it's important to them? What's motivating them? Boosting their sense of their change options, so they don't have to do cold turkey, that they have actually steps they can take in between, that they can do it at their level or chosen intensity, making sure that they're really clear and connected to the benefits of the change that they want to make. We can develop discrepancies. So that's where we're really exploring their values and goals, and how the behaviors that they're engaged in right now are in direct opposition to some of those values and goals, or maybe getting in the way of what's important to them. So really reflecting that ambivalence. We can also try to move away from any kind of writing, reflex, or arguing, which I'm going to talk about here in a minute, and really aim to have discussions that are framed from, instead of using yes, but you could do this, X, Y, and Z, going yes, and you could do. So it's really shifting from opening up their options and helping them to recognize that they can do more because that ambivalence is present. It's really helpful to review past successes and to try to dig out when they've met this types of challenge, because remember that the stages of change applies to any healthy change. So all of our patients have gone through something like this at some point, something like this at some point in their life that they can capitalize on. Once people are in action, that's where they're, remember, in the recent past, so they've already implemented their change strategy. So we don't need to do much more other than encourage their progress and maybe talk through any efforts that they're going for too big too quickly, right? We want to help them be successful in the long run and not take off or bite off more than they can chew, so to speak. Real quickly, a few words about relapse. It's important that we talk to patients about that as part of this model. Recognize that relapse is really common. It is not a sign of failure, and that we can normalize it as this is just part of their illness management. So we can help them avoid being discouraged, help them avoid any of the sort of cognitive things that can come online when they start to beat themselves up and say, it doesn't matter, it's never going to get any better. We just want them to re-engage with that change process as close to action as possible. So that's the stages of change model. Why is it important to understand the spirit of motivational interviewing, and where does that fit in? So this quote comes from 1660, and it says, people are generally better persuaded by the reasons which they have themselves discovered than by those which have come to the mind of others. And that's really at the heart of the spirit of MI, is recognizing that no matter how much we tell, no matter how many facts we give people, no matter how persuasive we might be, if somebody comes up with the reasons why they want to make that change, they are going to be so much more successful. It's going to be a much more sustained change than anything that can come from us. So with using motivational interviewing, what we're doing is something fundamentally different from the traditional medical model. We are working to have an effective conversation with people about the change process, and then support them as they take the steps that they choose. So really supporting their autonomy and agency in making that change. So MI is a collaborative, person-centered form of guiding, not telling, to elicit their strengths and their reasons for wanting to make this change. It's not necessarily a direct intervention. So it's not something that we give to the patient. It's a conversation or an interaction that we have with the patient. So that's why MI is really a very different approach, and why it's so helpful with helping people make any kind of positive change, because it is truly at its heart a collaborative, strengths-based, person-centered approach for helping people normalize and understand why they ended up in this situation, and feel like they have the power, they have the strength, they have the skills already to do the things that they want with their life. So it's not necessarily a collection of techniques as it is a way of being with patients. And it's really used to encourage any kind of healthy behavior. So if you have a patient that isn't necessarily ready to truly decrease or make changes with their use behavior, you can still use the spirit of MI to talk about how they can reduce other health risks, how they could use clean needles, or how they could be thoughtful about where they're purchasing their substances. We could talk about, getting STD testing or other infectious disease testing, other things that are in the service of harm reduction and improved health. It would all be appropriate to use the spirit of MI. I'm not going to go over this because you're going to get the slides, but just know that there's a ton of research on motivational interviewing. It has really large effect sizes when compared to other interventions for patients that are in that contemplation stage of change, regardless of what they're trying to change. So they've shown major changes with substance use behaviors, weight loss, blood pressure, you name it. If people are in contemplation and trying to make a healthy change, there's likely some good studies that support the effectiveness of MI. So what is the spirit? I think it's important to really think about when we're utilizing the spirit of MI, whether we're using some of the other techniques that are part of the model. Really what's at the spirit is appreciating the role of ambivalence and recognizing that that's an important part of change and a normal part of change. And so we don't want to discount it, and we don't want to see that as a bad thing. So ambivalence really just means feeling two ways about a thing. And if you've ever tried to make a change, let's say, for example, a lot of people have tried to lose weight at some point in their life. And so there's probably some part of you that recalls in that process, there was part of you that really wanted to lose weight or look better, feel better, whatever was part of that goal. And there was also part of you that didn't really want to let go of certain food choices or certain food behaviors, eating at certain times, eating certain things, maybe increasing or decreasing activity. That's the feeling two ways about it. And that's a completely normal part of any change process. It does not mean a lack of motivation. Motivation is there. Motivation is present anytime somebody's in contemplation, but they just have that other side. So you imagine that they're like walking on a fence, and they can see on one side all the great things that they want to get and they want to have. And on the other side of the fence are all the things that are comforting, that are routine for them, that they've been doing for a really long time. So both of those exist in one mind. And it's important that we validate and we normalize that, because what we're really trying to encourage people to do with decreasing their use, or even moving towards abstinence, or adopting new medication regimes, or going to therapy, any of those things, is we're trying to help them change a habit. And so we appreciate the spirit of MI when we really embrace that ambivalence is a good thing, and we can partner with the side of them that wants to change and avoid the communication trap. And the communication trap is whenever we get into arguing why they should change, why they need to change, what's getting in the way of that change. What they're naturally going to do is defend the status quo. That's exactly what happens anytime anyone tries to convince you to do something that you're not 100% committed to do. You're going to start telling them, yeah, but there's all this over here that is important and valid, and I'm scared to let go of. That's a normal thing. So we don't want to get caught in that trap. We don't want to have them start arguing for the status quo. We want to be aligning with the part of them that wants to make the change. So how do we do that? We have to avoid the righting reflex. So a big part of embracing and using the spirit of MI in all of our interactions is trying not to fall into this trap. So what's the righting reflex? It's the natural inclination that we all have to make something better for another person. So we see somebody suffering or hurting or making bad choices, unhealthy choices. As helping professionals, we naturally want them to stop. We naturally want to start listing off all the reasons why they need to stop engaging in that behavior, how harmful it is. But what's the danger with having that kind of an approach to the conversation? Well, when we tell other people what to do, how to do it, why they should do it, without talking to them and learning about their reasons why they're engaging that behavior, then it's going to create resistance, and it's going to create that, that communication trap where they're going to start to argue the other side. So as healthcare providers, we can fall into this righting reflex totally naturally, because we come to the table thinking, look, they don't see the problem. They don't know the problem. They don't know how to fix the problem. Or sometimes we even meet people where we think, they just don't care. They don't care about their life. They don't care about the consequences to their family. And typically that's not true. So when we have these beliefs in yellow, we are very likely to fall into the righting reflex, because we think, look, if I just increase their insight and help them to understand what they're doing wrong, they'll change. If I just give them knowledge, like explain to them all the consequences, explain to them the health effects, explain to them the risks, then they'll change. If I just give them skills to actually know how to make that change, then that will support them. But from this standpoint, when somebody's in contemplation, this is not actually what they need. So all we're doing is setting up to have this collision of worlds where ambivalence is present. Remember, there's two minds. So part of them really wants to change, and part of them is scared or doesn't feel confident or isn't totally sold. They're still getting something out of engagement in that behavior. And that's totally reasonable and understandable, that it helps them avoid their psychological pain. It helps them with physical pain. It helps them not think about their traumas, and so on and so forth. So they're obviously getting something out of it, and that ambivalence is there. And when we try to come after that ambivalence with the righting reflex, we just end up in this kind of a interaction. All we're going to do is headbutt, right? So patients can sometimes briefly change just to satisfy us. That's the patients that really want to be good patients, even though they're not necessarily at that place. So they might tell us what we want to hear. Sometimes they'll listen politely and just leave and do whatever it is that they were planning to do. They may protest and actually start to argue with us. And so we've all had those interactions. But at the end of the day, no one benefits from this. And unfortunately, we tend to blame the patient and say they're not ready, they're not motivated, rather than really looking at what happened. Maybe they were in pre-contemplation and there wasn't any ambivalence. So we were trying to do something with them that they truly were not ready for. Or maybe they were in contemplation and we didn't appreciate the ambivalence. And so we engaged in the righting reflex. So one thing that we want to do to get out of that trap, to stop engaging in that wrestling match, is to remember the rule. And so that means, number one, resist the righting reflex. Really work to understand your patient's motivations. What is their why? What are their values and goals about this behavior? And if you understand that, you're going to have so much more of a collaborative conversation around it. You have to really listen to your patient and not make assumptions that you're pulling from your life or from other patients' lives. It's unique to them what their reasons are for wanting to make that change. And then the main intervention that we are doing is to empower them to do it for themselves. So looking for areas of opportunity where they don't have the confidence, where they express that low self-efficacy, that's where we can really start to support them and exploring what they do have, what they can have. Because the foundation of this spirit is to recognize that patients already have what they need and that we don't have to give them anything. So you can see the spirit of MI is the foundation that everything else in MI is built upon. So what we're really trying to push is acceptance, collaboration, and evocation. So what does that mean? When we're trying to support patients in acceptance, that means that we're coming to the table expressing absolute worth for them. So that is an interaction where we show that we respect and we trust their decisions, that we're not coming to the table with any judgment about the behaviors that they're engaging in. This amazing thing happens that when people feel unconditionally accepted for whatever they're doing, for whoever they are, then they're not engaged in having to support the status quo. It actually frees them to start talking about and thinking about change for themselves and their own motivations. And it's hard to kind of have that trust and faith that it works. But in my research, and I've seen it time and time again, if we are just focused on how do I accept and empower the person rather than trying to change the person, they will naturally move towards positive change themselves. The other part of that's important with acceptance is accurate empathy. So that means that we're really striving not to have that sort of generic sympathy, but really striving to understand their meaning and values through their eyes. So that's that listening piece that's really important. And then lastly, it's having autonomy support. So acknowledging that even while engaging in some very risky behaviors, they have the freedom to make these choices. And so if we can accept that absolutely that is your choice to do X, Y, and Z, that can go a really long way because then they feel the freedom to not have to argue or defend those choices, but they can start to look at them more critically. And anytime you see movement around that, you can absolutely affirm and appreciate the strengths and the efforts that they're making, even if it's just showing up and having that conversation with you. So within acceptance, we're moving away from an authority perspective where we're telling them what they need to do or assuming that they just don't have the information, that they're unskilled, they're unknowledgeable, to an autonomy perspective where we're affirming their right and their capacity, their facility to make informed choices, and we're honoring them regardless of their use behavior. So essentially accepting them for exactly where they are and not making that acceptance contingent on their use behavior. Collaboration is where we're actively collaborating and we're viewing them as an expert in their own life. I may be an expert in some areas that we can lead to we can lend to the conversation. They're an expert in their life and their life experiences. And that is equal and just as valuable to the conversation that we're going to have. So you can think about it as dancing rather than wrestling, that both people need to be skilled and both people need to know the steps in order to dance versus wrestling. You could have one person that really dominates the other. And so we don't want to have that kind of an interaction. We really want to be viewing them as equals and having that back and forth with our conversation. We're exploring more than persuading. We're not trying to change them. We are just supporting them in their change goals. And so really remembering that it's done with the person, not for them, and honoring them that they are experts. So going from that confrontation perspective, where we're really trying to force them to accept a reality, the consequences of their decisions, provide that knowledge, we're moving towards a sense of collaboration where we're trying to develop a partnership that honors their expertise and their perspective. And then lastly, evocation. So what does that mean? That's where you're trying to evoke or bring forth what they already have. So like I said, most patients, I would say, if not all patients, have had some experience in their life where they have been successful against adversity, where they have made a positive change. At some point in their life, they have done this. So we know that they innately have the skill set to make these changes. So all we're trying to do with these conversations is capitalize on that and bring it forth. We're not waiting for them to be ready or trying to get them ready. They're already ready. They just may not be looking at it that way. So that's where we want to really focus on what their strengths are, what their motivations are, the why that they have for wanting to make the change, and seeking to understand and elicit that perspective. Because if we move away from they just need education, that assumes that they don't have the knowledge or the skill, towards evocation, what we're trying to do is really enhance their intrinsic values, their motivation for why they're wanting to make these changes, lining that up really clearly for them with their goals, values, perceptions, strengths, and life experiences. And so it's just capitalizing or evoking on what's already there. So again, when we're using the spirit of MI, the type of interaction that we're having with patients is not this, it's not wrestling, it's this. Okay, that's all I got.